For this first episode, we're just going to jump right into a topic that is very close to my heart, and that is healthcare. Healthcare is a human right, and as such, that makes it a feminist issue. I think we can all agree that the healthcare system that we have now is pretty much trash. Though we do have different opinions on how we want to fix the healthcare system. We all agree that premiums are way too high, that copays are out of control, prescription drug prices are way out of control. So we definitely all agree that we need to fix the problem, but there's not a lot of agreement on a solution. For those of us on the left who believe in human rights, we see nationalized healthcare as that solution. Most of the industrialized nations in the world have some sort of single-payer system. For instance, the British have their national healthcare system. Canada has a system that is localized by the province. Some single-payer systems also allow for private health insurance for additional features, such as elective surgeries like plastic surgery. So what is the difference between a single payer and a public option, for instance? A public option you have to buy into. The public option would actually be quite similar to the way that we do student loans. When it comes to student loans, our government acts as a bank that provides the loans for students. A public option would be similar, that the government would take on the role of a health insurance company, would sell a health insurance plan to a buyer, the public. Just as I mentioned, a public option, you do have to buy into it. You don't get enrolled automatically. What often happens in systems that have a public option, private insurers start offloading those people on their plans that are not healthy. So by offloading those people who are not healthy, they can lower their premiums and take on more people who are healthy and who don't need that much insurance. That way they don't have to pay out as much. So thereby they overload the public option and not be as efficient. Therefore, make it so that guess what your best option is the private and not the public. Whereas in a single payer system, the government is the only provider of health insurance. So the government can negotiate all prices. They can get rid of premiums, copays, and deductibles, negotiate prescription costs, negotiate with hospitals. That way they can lower the cost of services. And overall, since it's one system that is negotiating and not multiple healthcare providers, they can get the best prices for everyone across the board. So why should Medicare for all be our focus? Why is that the issue that I want to talk about? Let's look at this article by Natalie Shore that was published in Jacobin, in which she talks about the feminist case for single payer. She first talks about this group of women in the 1970s in Boston called the Boston Women's Health Book Collective. And they published a book called Our Bodies, Ourselves that sold millions of copies. She says that in the 1970s, the small collective became one of our first feminist organizations to demand a single-payer healthcare system. She writes, "Suffice to say that capitalism is incapable of providing good healthcare, both curative and preventative for all people. Cost-benefit analysis trades off the benefit to the people of collective public health in favor of the cost to the people of private, patch-up medical care. The capitalist medical care system can be no more dedicated to improving the people's health than can General Motors become dedicated to improving the people's public transportation." So as long as we have a private healthcare system, we can never have a system that provides good healthcare to everyone. The benefits will always go to those who can actually pay for it because they have no incentive of improving the public health network. Just as General Motors has no interest in rebuilding our transportation system, all they care about is selling cars. And it's the same with a private health insurance company. All they're interested in is their bottom line, selling health insurance and making money. They continue in a subsequent edition. "We believe that healthcare is a human right and that a society should provide free healthcare for itself. Healthcare cannot be adequate as long as it is conceived of as insurance." So this book was pretty radical for its day. As I said, this was published back in the 1970s. And even as early as June 2016, Planned Parenthood of California refused to endorse a bill for statewide single payer in California because they were focused on expanding and defending the ACA. So they cast it as a crusher for mostly women of color who work in healthcare administration. They argue that fighting for a single payer system is a distraction from the fight to defend the ACA. Even under the ACA, it's harder for women to get health insurance in the first place. The strains of child rearing and elder care make women more likely to seek more flexible employment, like part-time, remote, or freelance work. These forms of employment tend not only to pay less, but are less likely to include health insurance benefits. Furthermore, those that do provide benefits provide inferior ones. Companies with majority female workforces tend to offer less generous health care coverage than those that are majority male. And less than 1/3 of low-income workers receive any health insurance through work. Less than 1/3. Jobs paying at or around the minimum wage are most often occupied by women, the majority of whom are women of color. Trans women face even higher levels of poverty than cis women and are frequently saddled with impossible high out-of-pocket costs. She goes on to say that there are 25% of non-elderly adult women insured as dependents of a working spouse, which weakens their control over both their insurance coverage and their relationship. Health insurance has been found to be a common reason for getting married and for staying married when one would rather not, especially among low-income people. Upon the loss of a spouse's coverage, it's difficult and expensive to continue receiving the same care. COBRA coverage, a program that allows people who lose employer-based insurance, it is often the only way to maintain provider networks, but it's wildly expensive and eventually expires. The whole idea of COBRA is that it's a means to stay on insurance while you're in between jobs. It's not something that you can stay on for long periods of time. So ultimately, divorce leaves 65,000 women uninsured each year, with men being far more likely to maintain coverage after their marriage is dissolved. Fewer men are covered by their working wives' health insurance. More women are covered by their husband's health insurance. So when men divorce, they keep their health insurance while women lose theirs. Further, women's unpaid domestic work puts further pressure on the contradictory demands of home, work, and the need to access coverage. Women disproportionately shoulder the responsibility of caring for others, putting them in an impossible situation when it comes to child and elder care. In order to maintain health insurance, they can't take too much time off work. As a result, they're forced to spend a significant portion of their wages on private care for the hours they're on the job. For low-income women who don't qualify for insurance through employers, the problem can be severe, made worse still by right-wing efforts to impose higher copays and out-of-home work requirements on Medicaid recipients, or to defund programs like CHIP that help parents pay for their children's health insurance. None of this has to say that the Affordable Care Act was a total wash, but the problem with even the Medicaid expansion is that requires that your state, like the state that I live in, actually expand Medicaid. If you live in a state that refused to expand Medicaid, you continue to be screwed. Further, the overhaul of the individual insurance market, even though it helps somewhat to delink insurance from employment, it has done very little to actually fix any of the problems. And she says here that even under the ACA, even if premiums are more highly regulated, increased cost sharing, meaning, you pay some and your insurance company pays some, still means that patients pay stiff prices simply for getting the care they need. Reproductive aged women still spend over 60% more than men due in out-of-pocket healthcare costs. At the same time, while state ACA exchanges offer an alternative to employer-provided plans, the exchange plans remain inferior. Both tiers of insurance are plagued by narrowing provider networks and ever-rising out-of-pocket costs, leaving millions to forego insurance because it's too unaffordable, or find themselves stuck with plans they can't even afford to use. So in short, the dynamics that make the American healthcare system so hostile to women remain largely unscathed. The pervasive commodification of healthcare and dependent care in the United States, coupled with employment-based gatekeeping, engineers an impossible bind for women. They face more challenges accessing the healthcare system and pay more for their care when they do, out of lower incomes that are further squeezed by child and elder care costs. One of the other points that I want to make is that usually when we talk about a universal program, like a Medicare for all system, like free education, as a lot of these programs tends to be racial equalizers. And one of the ways that it does this is that it raises questions of deservingness. So this article out of Sphere, the magazine for science, medicine, and anthropology, says that Medicare for All challenge our ideas of Black deservingness. This article says, the healthcare debate is hardly just about health. Healthcare, representing a politics by other means, helps determine the socio-political and economic futures of women, Black people, and Black women, beyond the intrinsic health outcomes it directly produces. Amson Hagen is the author of this report, and he goes on to say that a single-payer approach to healthcare has far-reaching potential beyond simply paying for care. It could be a linchpin in reducing abortion-related mortality for all women, reducing Black maternal mortality, and improving health outcomes for Black people more generally via increased healthcare usage rates. Under such considerations, the moral underpinnings of a Medicare for All approach or an insurance-based healthcare payment scheme are all the more apparent. Proponents of the former system argue for the health-related and social benefits a universal healthcare scheme would produce. However, a Medicare for All program may prompt us to examine notions of merit and deservingness that have up to now been deployed to entrench racial inequality within existing American social structures. This article is bringing up, we have an illusion of choice in this country. Like we think, we can purchase our own health insurance, we can get coverage in whatever way we want, we can go to whatever doctor we want, but that's not the reality. In the system that we currently have, one, you don't choose your health insurance company, which doctors you get to see, what medicines you get to take, because you have to go by whatever is in network or out of network. You may not be able to get that MRI until you get an x-ray. They're practicing medicine on behalf of your doctor. They're not letting your doctor choose what medicines are best for you. They're choosing what medicines are best for you. They're choosing what tests are best for you. So your health insurance company is acting as a medical provider, not just as a way of paying for the cost of care. So whenever we talk about a Medicare for All system and the cost prohibition of a health insurance company actually acting as a middleman, we're not talking about the fact that they're actually practicing medicine on your behalf. And one of the questions that this paper raises is, do people deserve free health care? And so in a country where the ideas of having provided fundamental provisions like healthcare is devalued, because it is devalued in this country, in favor of a corrupt capitalist system, the question of people's deservingness emerges at every turn. Amid these debates, a further question emerges: which people deserve healthcare? Is it just the elderly? Is it just the very, very poor? Is it just pregnant women? Is it just the people who can afford healthcare? Is it just people who have a job? So throughout our history, the subtext has always read, Black people don't respect how well they have it. This is really demeaning. One of the things that a Medicare for All system does, it actually centers their care because it's going to provide health insurance to everyone. That's going to increase the rate that Black people are able to go to the doctor. It's saying that you too deserve healthcare because healthcare is a human right. In a 2017 Pew Research poll, respondents were asked if racial discrimination, as opposed to personal actions, is holding back African Americans who can't get ahead. And only 41% of Americans agree with this view, with 49% stating that Black people who fail to succeed in this country are mostly responsible for their own circumstances, with 54% of whites stating that African Americans themselves, not the effect of systemic racial discrimination, are responsible for their inability to get ahead in this country. It's unfortunately our racist system that keeps us from getting systems like Medicare for All, which would drastically improve the conditions of people of color. And this is brought out even further by another article from Bustle, in which experts and advocates explain how women specifically would gain from a Medicare for All system. Often when we talk about how to pay for Medicare for All, we often don't talk about who would actually be paying less. Because in a Medicare for All system, we would be getting rid of deductibles, premiums, copays. We would be able to negotiate for lower drug prices. And the government would be able to negotiate with hospitals and with doctors to lower the cost of treatment. While our healthcare costs would go down, our taxes would go up, but we would have a net savings. And the current conversation about paying for Medicare for All excludes who exactly will be paying less. And that includes women, people of color, low-income people, LGBTQ people, and other marginalized groups. Sarah Coombs, the senior health policy analyst for the National Partnership for Women and Families, argues that a healthcare system like Medicare for All would particularly be important for women. Women spend a disproportionate amount of their economic resources on healthcare. So expanding universal coverage is really essential to women's health and economic security. Medicaid is the largest single payer of pregnancy-related services in the United States. In 2016, funded 43% of all births. Medicaid coverage expires in most states 60 days after a pregnant person has given birth, despite the current maternal mortality rate in the United States. We're seeing that women are facing mortality and severe maternal morbidity up to a year postpartum. So it's essential to keep that coverage up to a year. A universal healthcare system like Medicare for All would allow anyone to have insurance regardless of reproductive status or income, meaning that new parents wouldn't lose access to life-saving postpartum care. Jillian Brandstetter for the National Center for Transgender Equality tells Bustle that easier access to healthcare would help transgender people in a number of ways. As we talked about earlier, trans people are more likely to live in poverty due to employment and housing discrimination, among other factors. And poverty, in addition to making it harder to afford care, can create and exacerbate health problems. When you're living in poverty, you're also more likely to face a variety of health issues ranging from psychological distress to substance abuse to HIV to a sedentary lifestyle to diabetes. Trans people more often living in poverty means they are more likely to experience those health problems, which means we are even more likely or even more desperately in need of a healthcare system that is affordable. Stephanie Nakajima, the director of communications at Healthcare Now, who also advocates for single payers, says the question of how the country would pay for Medicare for all is too often framed around a fear-mongering around taxes, not necessarily about a crisis that focuses on marginalized people who don't have health access. Americans are going to have to confront their anti-tax bias if they want to stop people from dying simply because they can't afford care. So ultimately, when we think about all the different benefits, it's clear we have to be fighting for a single payer system like Medicare for All, because that is the system that can directly impact women, the Black community, the LGBTQ community the most. So this is why Medicare for All is a feminist issue, because intersectionally, it centers those who are most directly affected by this type of program. If healthcare is truly a human right, then we need to be fighting for every single human to be able to afford healthcare. The most efficient way of doing that in this country at this moment is by expanding the Medicare system. That really debunks that argument from Hillary Clinton in 2016, who said that by getting rid of the ACA and fighting for a single payer system, we'd have to start from scratch. That's not true, because we have the Medicare system. All we have to do is expand it. So that argument is bunk. Medicare for All is certainly a compromise, but it is the best program that we have at this time. That way we can start now to build a universal and intersectional healthcare system. Thank you so much for watching this Killjoy Primer. If you liked what you saw, please give it a thumbs up. And don't forget to subscribe and turn on the notification bell so you never miss another video. See you Killjoys next time.